again the Taiwan experience. We had heard a month ago about the experience and how they are managing COVID-19 efficiently, that they've not lost any healthcare worker to COVID-19, and now they're back to tell us about the patient profile and their management options. As we all know, these webinars are CPD accredited. For any queries on CPD, kindly email us on knhcpd@gmail.com or cpdpharmacy@gmail.com. And for the pharmacists, we are really working hard to sort out your issues of CPD. And I believe by now you should have seen improvement on the CPD platform. Thank you very much. Right now we'll have Dr. Chia Wenli. She will present to us the experiences managing COVID-19, the patient profile and management options. Dr. Chia, you can introduce yourself and then start.
And good afternoon from far, far away country. I'm Jia Wenli, the infectious disease physician of National Chenggang University Hospital. Maybe some of your colleagues in our hospital, and hopefully one day the mutual visit could be restored. And today it is my pleasure to share this topic with you, far, far away, and which is management of the COVID-19 cases. And I'm not sure. 没播，也没播。你刚没播放可以？你没有播放？有啊，可以啊。我意思说你没有反抗，我影片有。So this is the global pandemic number as for August 11th, as yesterday. There are over 2 million people around the world reported to be infected by SARS-CoV-2. And over 700,000 people has died of this disease. Here you could see the countries of most disease burden. I also found the number of Kenya was nearly 27,000 by yesterday. And compared with other countries that listed on the previous slide, the epidemic in Taiwan is quite low. The epidemic is, I have to emphasize it because no one knows whether we will be the next United States. Of course, hopefully not. We actually have been testing over 80,000 samples and to diagnose 480 patients with the incidence rate around 2 per 100,000 people. All cases were confirmed by PCR, and most of them were imported cases, as you can see here. We have 7 days where 443 patients have been discharged from isolation with 3 negative tests at least 24-hour interval. Still, until yesterday, we have 30 patients are still in the negative pressure room. And there are several important timelines in the epidemic of Taiwan. We actually have the first wave. We have the first wave was patients from China. We quickly banned travelers from Wuhan and even mainland China after that. And we have the first household cluster in the end of January, just after the New Year holidays. And we also encountered small nosocomial infection in mid-February. Then in March, an extensive number of people coming back from the rest of the world were diagnosed and further caused some household cluster within our country. And also in April, we have another crisis developed on a Navy ship that we found 36 cases of COVID-19 out of nearly 300 crew members. And of course, you could see in May and June, we have quite peaceful 2 months, unlike the rest of the world, which have an increasing number of cases in the past few months. And of course, you can still see on the right, we do have some increasing number of cases imported, especially from Southeast Asia. And of course, we don't know yet now whether this would be the third wave, but we are very cautious of that because, of course, as other countries around the world, we are gradually open our border. So probably more suspicious cases or more more people with possible infection would come into our country. Okay. And because of the previous experience, we respond to this crisis quite early. So we, in our country, we recognize and manage the crisis as early as January. And it was during the Chinese New Year holidays, supposed to be the most important holidays in our culture. However, since then, all the medical personnel and the government officers kept working on this issue every single day. So most of us cannot take day off during this epidemic, even though we have quite low cases. And actually, the government has been addressing our national policy, maybe from media, from a lot of international news. So I would not mention too much details here, but I would like to spend a few minutes sharing what we were doing in our hospital during the most dangerous time. Okay, so this is our hospital building. We have separate outpatient building and inpatient building, and connected to medical college on the right side. If we look at these two buildings from the sky, and that will look like this way. Okay, there is a sky bridge connecting two buildings, and there were 7 exits and 2 additional walkway on the right side to the medical college. So triage and the segregation of suspicious cases and the control of people flow are the top 2 topics in the first place. So in the very early epidemic, in the beginning of the epidemic, we built a quarantine station in 10 days just outside of our emergency room. We also closed most exits, including the walkways to the medical college. And everyone who wants to enter the hospital building should go through the checkpoint to see if there is fever or not. If elevated body temperature was detected, and the individuals will be introduced to the quarantine station of ER. So sick people would not walk around within the hospital, sort of protect our environment to be a secondary source of spread. Okay, and if we have a suspicious or confirmed case, and they will be placed in the 12th floor. It is actually the top floor of our inpatient building, and this is where I mostly work. We actually have 11 standard negative pressure rooms, which shown in red color here, to accommodate these patients. And the route for the patients was designed as one way. So all the staff will go through the procedure. After all the staff will go through the procedure of decontamination after they finish their clinical care. So, and our staff also follow the one-way route to take care and do the decontamination after the clinical patient care. So during that epidemic, when we had patients in our ward, our staff said that the past few months actually was the most clean time in our life because we have to shower 2 to 3 times in a shift. And then we have the first case in our hospital. And the first case in our hospital was a 46-year-old female patient, just traveling back from Macau in the end of January. And she presented with fever and progressive upper respiratory tract symptoms, as you could see here. Fever was detected only in the first few days, but not anymore afterward. But the PCR for SARS-CoV-2 from nasopharyngeal swab was positive in the first 2 weeks and turned negative approximately at the 3rd week. So it takes quite a long time. And at the time, we do not use targeted drugs to the coronavirus because as you could see, it is just January and February. Our world did not know how we could treat coronavirus. And the other thing I want to mention is the antibody titer. You could see the antibody did not show until the second week of disease onset. So this is our first case. And of course, luckily, though we do not give her any targeted treatment, she recovered quite well. So she was discharged around 3-week hospitalization. And now we have known, after the past 6 months, the world gets to know this virus. I think it's in the fastest pace ever. So now we know it is a single strain RNA virus with some spike. You can see on the right side, some spike on its surfaces. And this is also a very core structure that targets the angiotensin converting enzyme 2 receptor. We call it ACE2 receptor. And this receptor will facilitate the virus to go into our human cells. So the destruction of the virus could be made depends on where the ACE2 receptor located. So it will correlate with the symptoms or clinical symptoms and signs that our patient will develop. And of course, we know the virus, but we still need some diagnosis tools. And as a physician or clinicians, we are told from our medical college and from when we are medical students, we are told that we diagnose the disease from the symptoms and signs the patient presented with. But the question will be, in the first place, even in our country, the symptoms with GI or we have some smell or or even neurological manifestation, but all these symptoms are not reliable. So at first place, most of us will rely on the travel history. And these symptoms be seen in the literature. These symptoms are quite important if the outbreak goes into community. And this symptom will be something that's more important than the travel history. The most frequent symptoms were still fever and upper respiratory tract symptoms, particularly cough, especially in patients with more severe disease. So patients with more severe disease will more possible to develop fever and other upper respiratory tract symptoms. And of course, it could spread the disease maybe more easy, more contagious. And while you can see here rhinorrhea, which is very common in other upper respiratory tract infection, but in COVID-19, the rhinorrhea is quite infrequent according to the worldwide experiences. And also we could see that from our patients. And it is I think it's kind of different symptoms compared with other respiratory tract infection. Okay, and sorry. Okay, and the meta-analysis also gave us some similar information because the fever here is fever is quite frequent in adults, but children is less frequent. And cough and dyspnea is could be seen in like half of patients. And here I want to mention this one, the diarrhea, because you could see some of them presented with diarrhea. And now the GI symptom was also considered as a co-symptom of COVID-19. And this has models. Because if you look at the literature, some experts also propose this model that coronavirus could also use the ACE2 receptor in the intestine to disturb the composition and the diversity of the microbiota and cause inflammation and ultimately diarrhea. So just as what it did to the pulmonary tissues. So the ACE2 in our body is a key factor to facilitate or to help the SARS-CoV-2 to spread and cause destruction in our body. And I guess everybody has known the information that even though rhinorrhea is not frequently seen in patients of COVID-19, but loss of smell, which is known as anosmia, and the loss of taste as ageusia, are reported more and more around the world. And this is a multi-center questionnaire study conducted in Europe, reporting 85% patients reported olfactory dysfunction, and nearly 90% patients reported gustatory dysfunction. And some of them, even over 10% of them, appear these symptoms before the traditional symptoms like fever, like cough. So the anosmia and ageusia will develop even before the traditional symptoms. So sometimes it could be the most preceding symptoms that we could detect in our patients. And also, you could see on the right side, it actually takes quite a long time to recover from the olfactory or taste dysfunction. Some patients have the symptoms more than 2 weeks. And one of my patients had actually been loss of smell for more than 4 months without any improvement. So here now, she still did not regain his function of smell. So she and we are very worried about the function, and we started to think whether it could be permanent or any other change in the future. Okay, and we also, in our hospital, we also have the first case presented with anosmia in Taiwan. And of course, back then, this case raised our CDC's attention on these new symptoms. And in this case, because it is like late in March, so we treated him with hydroxychloroquine for 7 days. And notably here, his antibody to SARS-CoV-2 did not appear until almost 2 weeks after symptoms onset. So all these serology tests, all these molecular tests, the timing for these tests are very important, because if later we will talk about the diagnosis tool, because if you use some antibody serology test to diagnose the patient, it will be it will not detect the patient in acute infection. And the last one is you can see from the literature that some neurological manifestation was eventually reported. And the case was published online in the end of March. This MRI image of T2 flare showed some hyperintensity within the bilateral medial temporal lobes and the thalamus. So that would be the upper fourth figure. And in MRI, we also evidence of hemorrhage indicated by the hypointense signal intensity on susceptibility wave image, which is on the left lower image, and rim enhancement on post-contrast image, which would be the B and H. So these findings are compatible with acute hemorrhagic necrotizing encephalopathy, and which was believed to be related to SARS-CoV-2 by authors. So I think this is also another manifestation neurologic of brain that we have to be looked at in the future. Okay, so we have mentioned a lot of diagnosis tools as symptoms, but all of these are non-specific, as we mentioned in the previous slide. But so we just need a more accurate diagnosis tools. And so currently, in the literature and also in the guideline, in most guideline of almost every country, the diagnosis of COVID-19 still should be made by biological testing, either molecular or antigen testing. And from the guideline by CDC or the National Institute of Health, we can see that they actually do not suggest we use solely the serological testing as a sole basis for diagnosis of COVID-19. just like as I said, that you will miss the patients in the acute phase, and the acute phase, the patient in the acute phase is those people that we have to focus on. Okay. So if you look at the website of United States Food and Drug Administration, the US FDA, you could find it is in a very fast speed that they created a lot of tests by emergency use authorizations. So if you look at the molecular diagnostic test for SARS-CoV-2, you could find the number. This is I checked the number yesterday, and you could see there are over 100 diagnostic kits, which was made by commercial that claim to be able to detect SARS-CoV-2. And if you look at the serology test, because the limited use of serology test, the number of serology tests to be authorized emergently is around 37. And in most of the guideline and also other notes, you will see the precautions for our use of antibodies, a serology test. This currently we still do not know how long IgM or IgG antibodies to SARS-CoV will remain present in the body after infection. And even if it is present, if they confer immunity to infection or not, that's the knowledge gap that the world do not know currently. So from the newest guideline, the National Institute of Health recommended against the use of a serology test to determine whether a person is immune to SARS-CoV-2. So our utilization should be very careful. Either if you want to diagnose a patient with serology tests, and that's risky because, like as I say, you will miss patients of acute infection. And also, if you want to check whether the patient with immunity or not to SARS-CoV-2, it is also not reliable. So if you are using a serology test, you should be very, very careful about that. Okay. And with these tools, we still have to know the specimen. Because as infectious disease physician, we know that if you get good quality of specimen, you could get right answer. But if you get wrong or poor quality of specimen, probably the answer you get might be wrong. So of course, we still need more specific or sensitive primers to be designed. And we still need to, by now, we still need to collect the right specimen to do the diagnosis. So the Hong Kong team has told us that the specimen from lower respiratory tract is more sensitive than those from upper respiratory tract. So as you could see here, the student yielded more positive results than the other specimen. Excuse me. And the specimen from respiratory tract is also better than those from non-respiratory tract specimen. So again, to obtain the right specimen to help our diagnosis is also very important. And from the beginning of the epidemic, there are two countries, and one is east and one in the west, seem to control the disease quite efficiently. I would not say effectively because you could see, including the South Korea, they still have some small outbreak. But I would say they control the disease efficiently in a very efficient way. They have one thing in common that they do a lot of testing. So the only testing you could get to find a patient, and you could do further containment and even further treatment. So, for example, like the United States, they did a lot of testing after its national outbreak, and which also turned to be the biggest number of confirmed cases in the world. So, but even the number is quite robust, but it is still the very first important thing that testing could only testing can lead to further strategy to control this disease. And before we start to talk about some treatment, I would like to share this figure with you, because some treatment potential could be figured out from this COVID-19 clinical course. So if you could understand and if you could feel the reality of this figure, and the answer to treatment might be in this figure. So theoretically, right now we have we know that there are 3 stages after SARS-CoV-2 infection, and the stage 1 on the left side, from left to right, and the stage 1 is the early infection, and this stage occurs at a time of inoculation and even early establishment of the disease. For most people in this stage, they often develop mild or non-specific symptoms such as malaise, fever, and a dry cough, while SARS-CoV-2 actually multiplies and establishes residence in the host, so they don't stop. Even the symptoms here are very mild. And during examination of this stage, lymphopenia might be a clinical clue for the diagnosis. So in the stage 1, we do not have a lot of clue to diagnose the patient, to detect a patient. All the symptoms here are mild or even non-specific, but you could probably see some initial change of the lymphocyte from their blood test. And we move to the middle part, the second stage, called the pulmonary stage. And viral multiplication and localization inflammation in the lung keep developing. During this stage, patient presented with a viral pneumonia with shortness of breath, with or without hypoxia. So image at this moment usually reveals bilateral infiltrates of ground glass opacity. And blood tests reveal increasing proportion of lymphopenia along with transaminitis, which is abnormal liver function, liver enzymes. And also markers of systemic inflammation may be elevated, but usually not remarkably so. So during this stage, you could see some more severe symptoms, and then you could see some abnormal chest imaging from our patients. And then, but otherwise, you could not probably some like inflammation marker, or even what you can see here, the percalcitonin is low to normal. And for a minority of COVID-19 patients, will transition into the 3rd stage on the right side. And this is the most severe stage of this disease, and which manifests as a extrapulmonary systemic hyperinflammation syndrome. So in this stage, the inflammatory cytokine and the markers such as we listed here the CRP, LDH, interleukin-6, D-dimer, ferritin, or even other cardiac enzyme will march elevated. And this significant elevation in this patient represents more severe disease, more severe inflammation, more activity of our immune system. And this will present similar secondary hemophagocytic lymphohistiocytosis. So in this stage, you could see patients presented with shock, ARDS, or even cardiopulmonary collapse. And these symptoms are really, really discernible. So you can see from the very bottom that generally different treatment stages should be applied to different disease stages. So during clinical diagnosis, we have to identify which stage that our patients are in. And the first and early second stage, viral antiviral therapy targeting selected patient may be reducing duration of symptoms, minimize contagiousness, and prevent progression to severe disease. But at late second stage and the 3rd stage, the most severe stage, Careful use of some immunomodulatory agents to reduce systemic inflammation is very important. And before our immunity overwhelming reaction and results in multi-organ dysfunction, and this stop to hyperinflammation might be beneficial to patients with severe disease. So we have to admit that despite anything that we do, all the treatments that we could do, the prognosis and the recovery from this critical stage of this disease are very, very poor. So this is what we have to judge if the patient are in this stage. So after, if you can understand and have the whole picture of idea of how COVID-19 goes, the clinical management could be tailored according to the different stages. And then you could see on the right side that some experts have proposed the mechanism to develop drugs to SARS-CoV-2. All these projects are under development, and you could still see multiple potentials from the graph here. And I guess all these things are this world's future. Like today, I'm going to focus on the most updated recommendation made by the National Institutes of Health of the United States. And I have ever made a talk to people in India in April, and this is the guideline that's released by US CDC at the time. So you could see here, but just less than 4 months ago, the science progressed too fast, so the guideline has been outdated. So, if you are taking picture of the previous this slide, please delete it. Please delete it because you don't have it is no need to take picture of this one. And as I said, the disease, the COVID-19 is really a new chapter of the scientific field all over the world. So clinically, I think currently we might still not be able to make it under control, but the world has tried our best to make it clear with the modern science. So knowledge is very, very robust. So if you take a look at these recommendations, that will be much, much different from what I'm going to tell you later. So here is the newest guideline that recommended the clinician how to manage the persons with COVID-19. So according to the most updated recommendation, they actually categorize patients into 5 groups. And the first one, from the asymptomatic, mild illness, patients of moderate illness, patients of severe illness, or patients even with critical illness. And we will talk about the treatments and management later, one by one. And for the first one, there would be those asymptomatic or pre-symptomatic infection. And this group refers to those only tested positive for SARS-CoV-2 by molecular diagnostic or even antigen testing. But even though they are asymptomatic, they are still considered as contagious. So they still have the potential to spread the virus to others. So the isolation for at least 10 days after the date of their first positive test is recommended by this panel. And in this group, for this group of patients, if they do not have symptoms, so even they have confirmed SARS-CoV-2 infection by molecular testing, we do not apply specific treatment for this group of patients if they do not have symptoms. So we do not treat symptomatic patients. And for the second group, that would be mild patients of mild illness. And this group refers to those with various symptoms and signs, but no shortness of breath, dyspnea on insertion, or normal imaging. And in the recommendation guideline, the panel actually say that they do not have sufficient data to recommend either for or against an antiviral immune-based therapy. But they do remind us that these groups with symptomatic COVID-19, even though the disease severity is mild, but for patients with some certain risk factors, they do have more possibility to develop or disease would be progressed to severe disease. And for those patients with certain risk factors, we have to monitor them closely. And these factors include this one. I guess these factors are very popular risk factors you could see from other diseases, including sepsis that we managed in the past. With these factors included like older age, patients of older age with chronic lung disease, with cardiovascular disease, with diabetes, with obesity, and those patients, those immunocompromised patients, and those in end-stage renal disease and liver disease. And these risk factors are something that we have to be very cautious of, because if you get a patient with these risk factors, but even though it is mild wellness or even asymptomatic, you still have to pay a lot of attention to the disease progression. So you have still to educate this patient to monitor themselves in a sophisticated way. And the third group will be patients of moderate illness. And this group refers to those with evidences of lower respiratory tract disease, but they do not have hypoxia. So their saturation of oxygen on room air is still quite good, over 94%. But in this moderate illness, so you could see some image evidence of lower respiratory disease. So you have to pay very attention to the pulmonary disease, because in this stage, the pulmonary disease can rapidly progress in patients here. So again, close monitoring of these patients is very recommended. And also because of the signs of lower respiratory tract disease, the empirical antibiotics for possible concurrent bacterial pneumonia is still suggested. And we have to pay attention to that and to evaluate the patient, whether it is, whether we have to apply some antibacterial antibiotics to these patients. And of course, we still have to evaluate the patient every day to see whether the antibiotic is still needed or not. And at this stage, and as you say, in the patients of moderate disease or more, or even severe disease, we should consider antiviral agents or immune-based therapy. And we will talk about these two agents later. And for the severe disease, the fourth group, this group refers to those with evidence of lower respiratory tract disease, but some hypoxia has been shown in our patient. Like the patient will have a faster respiratory tract respiratory rates with more lung infiltrate, more than 50% lung infiltrate, or even a lower oxygenation of oxygen. And for this group of patients, they should be placed in airborne infection isolation rooms, because we have to administer oxygen therapy immediately for this patient with obvious hypoxia. And also for these patients, we have to pay attention to that some maybe many arousal procedure would be done or would be applied on these patients. So for protecting our healthcare workers, well, the better way to prevent the nosocomial infection that we should place these patients in airborne infection isolation rooms, And also because they have upper years lung infection. So empirical antibodies for bacterial pneumonia should be still considered at the same time. And also we might think other antiviral agents or immune-based therapy should be evaluated among this group of patients. And the last and most severe patient would be the critical group of illness. And this group refers to those with respiratory distress, septic shock, cardiac dysfunction, or even some exacerbation of underlying comorbidities. And this group of patients, they should be placed, of course, should be placed in airborne infection isolation rooms. And we do have limited information to suggest that the critical care of this kind of patient with COVID-19 should be different from other critical ill patients. So in the recommendation, they actually suggest that we could take care of this patient based on experience from other life-threatening infections, such as I think most of us are very familiar with the surviving sepsis campaign. So in the recommendation, they suggest that if the patient goes to this critical illness stage, and of course, we still have to think about, do we have other antiviral agents or immune-based therapy might be beneficial to this group of patients. But the most important is that we just take care this kind of patient from the experience what you have from the past, from the experience that you take care of other life-threatening infections. That is important, because even though this is a new disease, but the clinical care might be similar. Okay. So later, we'll spend a few minutes talking about the antiviral agents. And first, we could see the first combination, which is quite popular, maybe in 2 or 3 months ago, which is hydroxychloroquine with or without azithromycin. And this combination gives us some hope of treatments based on this French study. And this is a very early study. The French study include 36 patients, and they actually categorized the patient into 3 groups. One received treatment of hydroxychloroquine, one group received treatment of hydroxychloroquine with erythromycin, and the third group did not receive any particular drugs. And you can see from the graph that the green line, which belongs to which represent the group receiving both hydroxychloroquine and erythromycin. And from the group, you can see in this group with combination of hydroxychloroquine and erythromycin, the patients clean their virus most quickly compared with the other 2 groups. So this study initially gave us a lot of hope that probably with use of the 2 drugs, we could reach negative PCR results earlier than no treatment. So according to this study, I remember at that time the world is very excited, and because if we can treat COVID-19 with hydroxychloroquine and erythromycin, it would be quite prevalent drugs. These 2 drugs are quite prevalent and are kind of cheap in most countries. Of course, in this study, they still mentioned if we apply these 2 drugs together, we have to pay attention to these cardio side effects caused by either hydroxychloroquine, or by erythromycin. So they said that we need a further study of these 2 drugs. And unfortunately, after the outbreak of the United States, so they do apply uh, they do apply hydroxychloroquine or without azithromycin in their patients. So quickly they could collect a lot of patient experience from real world. And this is a observation study on a large medical center in New York City, which as we know that in New York City at the time, they do have a big outbreak over there. So in a very short time, they collected over 1,000 patients. They do apply hydroxychloroquine or no, or not apply hydroxychloroquine. And as you could see the figure on the right side, and the probability of event free, the event means they free from intubation or death, is similar. They do not present, they do not show any statistically significance of among these patients. So in this study, they conclude that the use of hydroxychloroquine for treatment of COVID-19 was not associated with benefit in this large observational study. But of course, if you look at the limitation of this study, you could still see, because it is a observational study one. So you could see patients receiving hydroxychloroquine are older and with more comorbidities, they use more systemic steroids, and even they presented more severe disease. So in this study, they do analysis using propensity score, try to eliminate this difference between two groups. But as you can see here, the clinical significance does not reach. So in this study, in this observation study from New York City, the hydroxychloroquine is not effective to treat COVID-19. And then this is another study also done by New York Department of Health, and they try to test the different treatment strategies. So they divided, they categorized patients into 4 groups. The first group, they use hydroxychloroquine with azithromycin. And second group, they applied hydroxychloroquine alone. And the third group, they applied azithromycin alone. And the fourth group, they did not give any drugs. And in this study, and you could see the study results are still very disappointing, because patients in the treatment group did not show a decrease in hospital mortality rate compared with those who received neither drugs. And patients receiving both drugs, hydroxychloroquine and azithromycin, had a greater risk of cardiac arrest than patients who received neither drugs. And the odds ratio here is very significant. So again, we know the study results here. So these are observational studies, but they actually collect a lot of patients, the real world patients. So the results are quite benefits provide a lot of knowledge to us about hydroxychloroquine and azithromycin. And of course, I still have to mention, because all these studies have their own limitations. So of course, in this study, you could still see a patient in the treatment group had a more severe disease. So even they do adjusted analysis, the baseline confunding might not be well measured and further bring impact on the results. But because of these 2 large-scale studies from New York, and actually, so the panel of the National Institutes of Health, they recommend against use of hydroxychloroquine or hydroxychloroquine plus azithromycin for the treatment of COVID-19. So except you could design a well-designated clinical trial. So for hydroxychloroquine, actually, according to the current recommendation, it should not be applied on patients of COVID-19. And the other drugs that used to give us a hope, that's the lopinavir and ritonavir, the combination of a HIV drugs. And this is the very beginning hope that this is a study from China. And you could see patients using lopinavir and ritonavir have would be more possibly to improve from COVID-19, though the statistic, though they did not reach the clinical significance. But in this study, you could probably see the trend here. But of course, after all the other studies that reported later on, now I think we have known that the mortality. The administration of lopinavir and ritonavir did not improve the mortality of COVID-19 cases here. And if you look at the virus, that viral clearance, is it possible that we could clean the virus earlier? And this is another study done by my friend, Dr. Chen, and they actually choose 5 patients, 2 of them treated with lopinavir and ritonavir. The other 3 treated do not treated with lopinavir and ritonavir, and then they collect the nasopharyngeal swab for SARS-CoV-2 PCR. And in their study, they still reported that lopinavir with ritonavir failed to shorten the duration of SARS-CoV-2 shedding. So, from both perspectives of clinical and the viral clearance, the lopinavir and ritonavir failed to show the benefits to treat COVID-19. So for the panel, they actually recommend against the use of lopinavir and also other HIV protease inhibitors for the treatment of COVID-19, except you could design a good clinical trial to try to be against the previous study results. And the last one, I think that's also the worst future. Okay. And that's remdesivir. And remdesivir is a direct antiviral agent. And this is the very first report from remdesivir. And this is a compassionate use from United States, from Europe, from Japan. So they collect only 53 patients. Most of them, all of them have a lower oxygenation of oxygen on ambient air. So all these patients are moderate disease or are more severe to moderate disease, moderate illness. And in this study, in the very early observational study, we could see that most of the patients, when 36 out of 53 patients got improved after they are administered with remdesivir. So in this very early study, we see some hope from remdesivir to treat COVID-19 case. But by the 28th of follow-up, you could see the clinical improvements as just by the borderline of clinical significance. And you could see from right side that in this very early study, you could see the patient of non-invasive oxygen support gain more benefit than patient with invasive oxygen support. So this is a very preliminary data to give us hints that probably not all patients will be benefit from the single drug. Probably we should select some patients, select some targeted patients to give these drugs and to bring benefits to these particular patients. And more recently, we could see a more inspiring study results. And this is a multi-center studies in several countries. And you can see here, it randomized over 1,000 patients for treatment and analysis. And all these patients, and this is a phase 2 trial, so they actually randomized the patient into 2 groups. One will be given remdesivir, the other one will be given placebo. And all the remdesivir will be given intravenously. And they actually include patients with COVID-19 requiring hospitalization and with evidences of respiratory tract involvement. And finally, over 1,000 patients were included in the final analysis. And you could see, if we look at the overall analysis on the right figure, and you can see the proportion of recover from COVID-19 is better among patients receiving remdesivir compared with receiving no drugs, and it actually reached clinical significance. So in this overall analysis, it actually gives us a great hope for this medication. But we have to still pay attention to the subgroup of this patient, the subcharacteristic of this patient, because if you look at the subgroup analysis, you could see not all kinds of patients will be benefited from these single drugs. For example, you could see on the left side, if the patients, even if they are diagnosed with COVID-19, but if the patients are not receiving oxygen, the recovery rate is similar. They do not reach the clinical evidence, but of course, as you can see, it is from the 95% confidence interval is from 0.94 to 2.03. So it is probably just in the borderline here. But if you look at the right side, the patients receiving oxygen, and you could see if you give this group of patients remdesivir, you could see a significant improvement and significant proportion of recovery from COVID-19 among this patient group. So this is a most proposed patient group that we should give a single, give these drugs. And okay, and if you take a look at the more detail, you take a look at further treatment group, and you could see if you have patient receiving high flow oxygen, even either non-invasive mechanical ventilation or invasive mechanical ventilation, or even ECMO. For these patients of critical illness, what we categorize in the previous 5 category group, the patient of critical illness, they could not benefit from remdesivir in this trial, in this phase 2 trial. So again, according to this phase 2 trial, but as you could, it is very shocking and very inspiring that this is a phase 2 trial, but they include 1,000 patients in this single trial. But in this trial, we can say that after according to this trial, the panel actually recommends remdesivir could be prioritized for use in hospitalized patients with in hospital patients with COVID-19 who require supplemental oxygen, but not those on high flow oxygen, not those on invasive ventilation, not those on mechanical ventilation, or even ECMO. So if we correlate back to the patient group, and you could see these patients are those with moderate to severe illness, but not those in the group of critical illness. And of course, this recommendation was set according to that the remdesivir might be limited usage, okay? Because probably we could probably a single country or a single institute could not get as much as remdesivir in the future. So if the remdesivir, the amount of remdesivir is limited, and we have to identify these patients with most potential to gain benefit from these drugs. Okay, so remdesivir, we can still look forward to like future studies and post-factory or even further study to find out whether it could be more beneficial. But of course, if you look at the recommendation, you will still be very worried about the later, those who are in a critical illness. And again, the panel did not say it recommend against it, but I think they just said that they cannot make a recommendation either for or against these studying remdesivir among this group of critical illness. So I think it comes back to the clinical judgment by the physician or the intensivist. And the last one, we'll talk about some immune-based therapy, because this is probably the future. This is probably something that we could do on the group of critical illness. And the immune-based therapy is actually that they do have a lot of different kinds of immune-based therapy. You could see convalescent plasma from recovered patients. Some immunoglobulin products are being produced, and some studies are doing some neutralizing monoclonal antibodies directed against the SARS-CoV-2. So all these things on the left, I think they requires much more study to prove whether it is effective or not. And on the right side, they do have the other part of immune-based therapy. The most popular one would be corticosteroid, because corticosteroid has been used in the past in treating some patients. Yes, so from the beginning, we talk a lot about how corticosteroid could be beneficial to these COVID-19 patients. And of course, given the hyperactive inflammatory effects of SARS-CoV-2, probably these agents modulating the immune response are being a possible adjunctive treatment for the management, especially for moderate to critical COVID-19 cases. And recently, we do have some study about that the corticosteroid, the dexamethasone. And you could see a study here from the United Kingdom, and the study called randomized evaluation of COVID-19 therapy, called the Recovery. And this is an open label trial. And they categorize patients into two groups. One is usual care, and the other one is oral. The other group of patients will be applied either oral or intravenous dexamethasone, 6 milligrams once daily. And in this study, they conducted in the United Kingdom, they included 6,000 patients in the final analysis. And if you look at the right side, you could see the patient receiving dexamethasone have lower mortality along with the clinical course. Compared with the usual care, and the rate ratio of mortality is 0.83. So after this study, we know that the dexamethasone might be a beneficial choice of treatment for the patient of COVID-19. But again, it might not be beneficial to all subgroup of patients. So in this study, they do some subgroup analysis. And if you look at the disease severity, and on the right side is the patient of mild disease. In the middle one, there will be moderate illness, and then in the last one, that's the patient of critical illness. And from these three graphs, you could see that the giving dexamethasone to patients of COVID-19 could be beneficial to these two groups of patients who are requiring oxygen and requiring mechanical ventilation, but not beneficial to those on the right side, not beneficial to those who do not need oxygen supplements. So again, this also reminds us that probably a choice of treatment is possible, but it might not be overall applied to all different kinds of patients. So again, we still have to try to find the targeted patient to give the right choice of treatment. So the panel actually recommends using dexamethasone for the treatment of these kind of patients, especially who are mechanical ventilated, and especially in patients who require supplemental oxygen. But if the patients are not required to receive oxygen supplements, please, the dexamethasone might not be beneficial in this kind of patients. So that's correct. So according to the previous slide, I think there are two possible choices of a treatment that we could apply, but we have to choose very carefully what kind of patient that they are most in need, and they could gain the most benefits from the two different treatment of choice. And a lot of people will very interested about the prevention of prophylaxis, but according to the study and according to the panel, actually they do not suggest any agent for even pre-exposure prophylaxis or even post-exposure prophylaxis. So except you could design a good clinical trial. So maybe in the future for prevention or prophylaxis, we still need the vaccine. And of course, we look for vaccine very a lot. Okay, so in summary, only when the potential patients could be identified, the following strategy including containment or treatment could be done. So timely measures including proactive real-time surveillance with expansion of laboratory capacity is very important for in different countries. And for public health officers, we have to watch our community spread. And for infection control physician in the hospital, we have to pay attention to nosocomial infection. And for some potential drugs, we listed here, but more study are needed. But of course, compared to a couple of months ago, we do have some good evidence to prove some good drug of choice here. And okay, so I guess that's that's everything for my talk. But I still have to remind that all of us should have to get the basic skills, the hand washing and the wearing mask. And sorry, I know I have used a lot of time.
Thank you very much for your presentation, Dr. Chia. We really learned a lot from the Taiwan experience.
Excuse us, we do not hear you.
Yeah, hello.
Thank you very much, Dr. Chia. My apologies. I've had a bit of internet issues. Thank you so much for your presentation. We've learned a lot from your experience in Taiwan, and even now in the patient profile and the management options. And I like the way you've broken down the presentation, and a lot of us following through have actually understand how COVID-19 works, the receptors that it binds to, and the management for both the asymptomatic, mild, and moderate. Just a few questions that maybe I have, and some that I've seen the attendees asking. On your presentation, you said that you're getting 3 negative cases before you discharge patients.
Yes, it's a national policy that we have. Yeah, according to our previous national policy, we do request 3 negative, we do request 3 negative PCR results on a base, on an interval of 24-hour interval to discharge our confirmed cases. So we actually do a very strict quarantine and containment policy here. But of course, we do discuss this very strict policy after the previous outbreak here, because the longest isolation time for our patient is nearly 3 months, 86 days, if my memory is right. So they are quarantined in, they are put, the patient is put in isolation room for nearly 3 months. Even though after the first week, the patient did not have any symptoms of that, did not have symptoms of COVID-19, he could not go out. He could not be released from the isolation room. So that gives our patient, they give our patient a lot of emotional and psychological stress. So we do discuss, do we have to release or cut the negative results to maybe 2, but it is still under discussion. But I have to say, because right now we still do not have much cases, so so that's what we can do here. But according to guideline, which was written by United States, and they do have a robust number of patients. They actually suggest that patient, if the patient is free of a symptom for, I think it's 3 days, and it could be considered to be discharged or to be de-isolated. So I think that depends on different countries with different patient number.
So what is the average duration to the first negative test among your patients from diagnosis? From diagnosis to the first negative, the average, how many days?
In Taiwan, if my memory is right, the median negative PCR, in the median day to first negative PCR would be around 3 weeks, 20 days.
20 days.
Yeah.
From the diagnosis to the first negative.
Yeah.
20 days.
The median day, if my memory is right, it's around this day. So it takes time. So but of course, according to our experience, the most patients, especially those of mild disease, they do not have any symptoms after first week. So the hospitalization will be very bored for them. They cannot do nothing. They can only stay in a small room and to have their day for 3 weeks or even more. Yeah.
Anthony, we cannot hear from you.
Thank you very much. And I'm not sure, can you hear me now? Hello?
Hello.
Hello, you can hear me?
Yeah, yes, we can hear you right now.
Okay, thank you so much for your presentation and for answering your questions. And we're almost coming to the end of our presentation. It's now 3:19. There's a comment from Lucy Mbogo saying excellent presentation, from Dr. Raj, commending you that it was a very good informative presentation from Taiwan. And the question that he's asking is comment on the use on remdesivir. Does it have any side effects? That's what he'd like to understand. And I think also from my end, even during your presentation, you're seeing that there are several waves, and the third wave is imported from from different countries. I was a bit curious. Have you lifted like the ban for people to travel into and out of the country, and how does this look like in terms of the COVID numbers, the COVID-19 numbers?
How does it remain it?
Actually, I have to say, I do not. In Taiwan, we do have a research site in Taipei, but in my site, we do not have experience on remdesivir. But from the literature I see, I don't see any severe adverse effects have impact on mortality or even I don't remember the specific numbers, but I don't think a lot of patients will stop remdesivir because of the adverse effects. So probably compared with the benefits, most of the patients could tolerate it through the treatment course. And do you ask another questions about the border control or something?
Yes, the second question was on the number. Have you lifted the ban on travel into and out of Taiwan, and how is that affecting the numbers?
Okay. As I know, right now we do not, we still do not allow the foreigners to come into our country. So the people entering Taiwan every day is, I don't remember the exact number, but that would be less than maybe 1,000 or 2,000 only. So we still do a very strict quarantine policy here. So everyone from all over the world should be placed in quarantine, home quarantine for 14 days, for 2 weeks after they are released. So so we still try to contain this disease in a small area. And but of course, we do not restrict our people to go out. If any other country could accept our people, they could go out. But of course, now we will see some sporadic cases that they are reported positive when they go back home or when they go to other countries. And also, so that this sporadic case will raise our attention to that we have to admit that probably we do have some small community outbreak or some silent community cases. But no matter what, we under our surveillance of severe pulmonary disease, we do not see severe cases of COVID-19 in our community. So we still try to monitor and survey all these possibilities to find the potential and silent cases here.
Thank you so much for your presentation. We've actually come to the end of our period for the webinar presentation. Thank you so much. It's been a really nice and informative presentation, and the breakdown of the presentation has been really good. Thank you for enlightening us on what your practices in Taiwan, and I think even as Kenyans, it's something that we should emulate during our fight against COVID-19. Even as we come to the end of the session, I'd like to make a slight change to inform everyone of the slight change of the presentations. Tomorrow we will be having a presentation on the ultrasound in managing COVID-19, and it will be at 7 p.m. in the evening as opposed to the presentation from 2 p.m. So kindly note, ultrasound in managing COVID-19, 7 to 8:30 p.m. And we will not be having a session from 2 to 3:30. On Friday, we'll be having 2 sessions. From 10 to 12, we'll have experiences in managing COVID-19. Then from 2 to 3:30, we'd like to look at how do we set up an ICU facility in light of COVID-19. We'll have experiences from various counties and various anesthetists sharing the best ways to set up an ICU facility. So for these sessions, kindly tune in, and we will be able to learn a lot from this. Thank you so much for the presentation, Dr. Chia Wen, and for all our attendees, thank you for attending. Thank you to Dr. Kimuthi and Mr. Mwenda in the background for organizing the webinar's presentations. Have a good afternoon. Thank you.
Bye-bye.